All right, so we have two speakers with us today. We have Michael T. Anderson, and he is the Division Vice President for Quality and Pop Health in the Virginia Mason Franciscan system, which they do an excellent job, I think, overseeing several 100,000 lives. So thank you for joining us, Mike. And we have Nick Jansson, who is an internist and the medical director for Ambulatory and Quality and Pop Health for Virginia Mason Franciscan. So excited to hear about their projects.
Oh, good morning, everyone. Thanks for your attention today. I wanted to just kind of start us off by talking about just what the population health impact is of colorectal cancer screening. It might be obvious to many, but it just bears reminding. Colorectal cancer ranks number 2 for cancer deaths in the United States in men and women combined. Lifetime risk is about the same between men and women, 1 in 23 for men and 1 in 25 for women. And in 2021 alone, there's already been 150,000 new diagnoses of colorectal cancer and almost 53,000 deaths already. We're seeing some alarming trends in deaths in colorectal cancer in people, increasingly younger people, less than 55 or younger. And that's what's led to the USPSTF grade B recommendation, which shows moderate net benefit in screening folks between ages 45 and 49. That's not part of other guidelines yet, but NCQA and HEDIS plan to vote on this age this fall. And if it passes, likely payers will follow. But I think it's important to mention that because early detection really does save lives. Right now, there's 1.5 million survivors of colorectal cancer in the US. And without early detection, we'll see more of these stage 4 cases that really has only about a 3% chance of a 5-year survival. The number needed to screen to save 1 year of life due to colorectal cancer is 339. Just wanted to talk a little bit about how the metric is fulfilled. The percentage of patients 50 to 75 years of age who had appropriate screening for one of the following modalities. So you'll see here Cologuard, which is our FIT DNA stool test, a fecal occult blood test, Guaiac, which requires 3 stool samples, FIT, as I mentioned, and then FlexSig colonoscopy or CT colonography. Any of these will satisfy the metric in this age group. Documentation in the medical record must include a note that indicates the date and when the colorectal cancer screening was performed and the results of the screening. People that were excluded, hospice, people with active colorectal cancer, people who have had a total colectomy, folks 65 and over with institutional special needs plan or long-term care. What's important to note also is that digital rectal exams are also doesn't count for the metric. Fecal occult blood tests that are performed in the office, especially in the setting of a digital rectal exam, also don't meet the measure requirements. And one other just last thing I wanted to note before we move on is this involves a lot of shared decision making. And it's really, that's the root of this population health impact. It's the relationships that we have with our patients to share in that decision making. And really what we've messaged to our folks is that regardless of whether you get a stool screening test or a colonoscopy, it's really the best test is the one that gets done. Michael, I think you wanted to talk about this one.
Thank you, Dr. Jansson, and thank you all for being with us today to share our improvement journey with you. Colorectal cancer screening was identified as a strategic objective for the Pacific Northwest Division because we felt it was meaningful, it drives value, there's significant variation throughout our division, and it adds quality adjusted years of life to the communities that we do serve. So we utilize the model for improvement as our improvement methodology when scoping out our problem. And ultimately, what we were trying to accomplish is to increase colorectal cancer screening rates to 70% through shared decision-making, population targeting, and improved throughput processes by December 31st of 2020, and continue this journey until we achieve 80% in every community we serve. We do know that the colorectal cancer screening is preventable, treatable, and beatable. And as Dr. Jansson did say, early detection saves lives. And if we catch it early, we can cure it. A stage 4 has as low as a 3% 5-year survival rate, but if caught early, a 90% survival rate. So we can keep our patients at home with their families living longer, fulfilled lives. So this is a driver diagram. And a driver diagram is a visual display of what drives or contributes to the achievement of our project aim. And we utilize this driver diagram to really identify what those change interventions are, and really utilizing the theory of profound knowledge is, which is what knowledge or education do we need? What systems and structures need to be addressed? Where is our variation? And how can we influence our providers and patients to really work together to navigate our healthcare system to complete this life-saving screening? What's interesting about our improvement project is that we launched our initiative in February of 2020. Well, as we all know, the pandemic started in March of 2020 and really shut down our improvement project. So we had to come together as a team and really look at ways to really rescope this problem, identify which changes or interventions that we could address, and really target vulnerable populations that we could really engage to complete healthcare plans whenever they were ready to utilize our systems again. So first we did an evidence review, and in 2019, JAMA published a study that produced evidence when you achieve 53% completion in a population for the annual wellness visit, you will see double-digit increases in cancer screening, comprehensive diabetes care, and vaccination rates, ultimately lowering the total cost of care by $465 per patient per year. And we thought this was a great recovery effort for our clinicians, knowing that this visit type could be completed virtually. And then we studied what the relationship was between annual wellness visits and colonoscopies across our 29 primary care clinics. And as you can see, the more AWVs that are completed in a clinic, the more colonoscopies, really depicting a very strong relationship. So working through the theory of profound knowledge and our different drivers, the first thing that we addressed is what our systems and structures were. And did we really have the daily standard work in each of our clinics that could be implemented? So were we huddling? And were we using these huddles to forecast for our patients that had visits that day? Did we have the proper tools and tools for our teams to be successful? Did they know who the patients were that needed to be screened? And did they know whenever they were coming in whether or not to have those orders prepared during their pre-visit workflows? Was our EMR optimized, and was it able, did it optimize to be able to actually initiate the order? And did our staff have the autonomy to really have these discussions with our patients, to have these orders pended before they actually had the visit as part of our rooming process? So those are things that we all implemented, but also how we outreach to our patients, whether it be for an annual wellness visit or a Cologuard test, and really how we engage them with tips, key tips on what is successful when talking to patients. The next area we addressed was education, and it wasn't just education for our patients, but also our care teams and our providers. First and foremost, the best screen is the screen that gets done. So working through those shared decision-making processes. We have shared decision-making cards in every exam room throughout all of our primary care practices in the system, so they can really start to have those discussions on which one the patient feels comfortable completing during that time. In our high volume, high impact clinics, we have visual primers, not only in our waiting rooms, but also our exam rooms, really starting to engage the patient before we start to have those conversations. And also education they can take home with them, whether it be brochures, in addition to that, to our after visit summary. But we also educate our care teams on the population health level impacts of colon cancer, and how it really impacts communities, our payers, the patient's families, but also the care team, and how we can really begin to tackle this as a community. The next is understanding variation. So how are we performing? across our healthcare system. We do have analytics that are attributed at the division, the region, the clinic, and provider level. These are real time. They update daily, and they really allow us to target and have real-time interventions for those patients that are overdue for their health maintenance gaps. We also have management scorecards that really drive those process metrics and update weekly to show them how their systems of administrative care are functioning. And this really allows us to begin having those honest conversations about how our systems of care are functioning. And if they're not, what we can be doing better, or what other interventions that we could be placing to help improve the quality of care delivered to our patients. And then we moved into the PSA cycle. The majority of the improvement that we're focusing on, we had several different improvement cycles, but was the annual wellness visit. And it's more about the front end work that's required to get the patient set up to navigate our system to complete their colorectal cancer screenings. So we went through several cycles. We used the PDSA, we tested change on a very small scale, and we did several different ramps. And the first thing that we did was we outreached all of our patients that had active MyChart. And if they didn't have an active MyChart, we use USPS. Our hypothesis was if we utilize a primer to engage our patients, that they will be more likely to engage in the conversation whenever they do engage with their healthcare team. 1 week later, we began to follow up with phone calls to our patients. And this is where we really saw significant success, is that 98% of our patients were reviewing our MyChart messages. They were receiving their letter in the mail. That way, when we called them, they knew what we were calling about. It's time to come in either for your annual wellness visit or to discuss your healthcare preventative plans. And for our patient, or for our staff, we wanted to make this make daily achievable goals, knowing that this is a very large population and can seem somewhat overwhelming. If we are able to really engage all that do outreach in just small achievable goals of 5 daily outreach calls, then over time we know that exponentially that will grow. If you had five team members making 5 calls a day, that's 25 a week and 300 a month. So you can really, from a clinic perspective, really get those important touch bases. In our third cycle, we began to implement our phone scripting and standard outreach documentation. So we really wanted to standardize how we were talking to our patients. So we had very similar messages to engage them and have them activate. And then lastly, we reorganized our gap list logic, and we really used machine learning and upwards of 90 dependent variables to target those patients that we felt were more likely to complete their cancer screening versus those that did not. And as you can see, we started off in the Seahurst Clinic and then moved into the Enumclaw Clinic and saw significant improvement, moving as high as 76% completion for an annual wellness visit at Enumclaw and over 50% improvement at Seahurst. And this is one very large clinic and one of our smaller clinics. What I do want to point out is the success in scheduling outreach. We've seen upwards of 50% improvement when it comes to utilizing the primer prior to reaching out to the patient with a phone call. And we've continued to maintain those rates as we've spread this change. When it comes to spreading change on a large scale, we use Cotter's 8 steps. So we really wanted to create that sense of urgency, enlist that volunteer army with a similar strategic vision, generate short-term wins so we can sustain acceleration, and then we reinforce that to ensure that we could institute that change. So we launched a campaign with all of these resources to our 29 care clinics for colorectal cancer screening month this past February, and ran it through August. And during that time, we saw significant results. We were able to schedule 5,000 annual wellness visits, 1,000 additional physicals, 973 colonoscopies were scheduled, 2,700 screenings were ordered, and 1,300 were completed during that time frame. We looked at the population level impact for that. We were able to add 8.16 years of life to our communities in that short window. We detected 7 cancers that we were able to put their care plans in place. and averted over $4 million in future care, which is just absolutely significant and really driving that definition and value of what we were trying to achieve. And before I talk about the outcomes of colon cancer screening in general, first and foremost, we always count our successes in the number of years of life saved. And during a pandemic year, over the last 12 months, we've been able to add 111 years of life saved due to the 3 major screenings, and 43 of those for colorectal cancer screening. Next slide. So that's 43 more men and women that get an extra year of life with their families, another Sunday dinner, another holiday, because we screen for colon cancer screening, and that's ultimately what we're trying to accomplish. And if we dug a little bit deeper about what the other impacts are, an additional $10 million in estimated future costs were averted due to colorectal cancer treatment. So thinking about how that impacts the healthcare system, the communities, and everyone really involved, just significant impact. And we're keeping our patients out of the hospital, 426 extra days that they got to spend with their families due to our aggressive screening programs. And this is a look at the impact. And if we look, we see the very strong correlation as we improved annual wellness visit and how that increased our colorectal cancer screening orders, but also our colorectal cancer screening compliance. We saw a 57% improvement in AWV scheduling, which correlated to a 300% improvement in the number of colorectal cancer screening orders on a monthly basis. That contributed to a relative improvement of 34.72% in annual wellness visit completion and a 10.42% colorectal cancer screening improvement. These are very large denominators. We have 85,000 patients in our denominator for colon cancer screening. So a 1% improvement is over 800 patients screened. And we have 45,000 patients in the denominator for annual wellness visit screen. So the magnitude of this program is substantial. Dr. Jansson?
Thanks, Michael. Yeah, I just wanted to share with you all just some of the lessons that we've learned. I think it's really important that we automate wherever possible. And really what that means is, as Michael showed you, automating analytics and automating that the showing of that to our clinic teams so that they can motivate their teams and motivate patients to get in. I think that automation really allowed for that sort of real-time influence to get people in to do these screenings and get annual wellness visits scheduled. Patients respond really favorably to primers and visual awareness. As Michael showed you, those different brochures and posters we plastered everywhere. I can't tell you how many times I walked into a room and a patient and I would have some dialogue around one of those visual awareness tools. Management alignment and accountability is so key to continuous improvement, not just for colorectal cancer screening, but for any kind of quality improvement that we're trying to do. And I think a lot of these slides, when I look at it, are celebrations of the leadership's ability to motivate the teams and the team's engagement and buy-in and carrying that forward to live out and make these processes is what's really ultimately led to these people getting screened. Visit types that focus on preventative services increases patient compliance. Physician buy-in and engagement is so important, as I mentioned before. And this has to be fun. We notice when we have friendly competition, again, with the benefit of automated analytics and this being very transparent to us, friendly competition makes spreading the fun easier and spreading the goal of getting annual wellness visits and colorectal cancer screening discussions done. And we've been very blessed to have a great relationship with our GI service line. The engagement with them obviously is imperative for sustaining and improving these efforts. The next steps for us, continue pushing annual wellness visit scheduling, and colon cancer screening is a really focused goal. Establishing and maintaining our relationship with Exact Sciences around our Cologuard tests that we promote for people. Partnering with GI to improve colonoscopy throughput. As Michael mentioned, the spirit of this work is to get people in and have those conversations and get people scheduled. But then the next phase of this work is let's get that throughput and get those colonoscopies finished. Utilizing equity reporting to target specific populations, studying the impact of annual wellness visits completion on cancer screenings in general, the incidence rates, the hospitalizations, that's all data we really want to continue to study and connect well, because I think that will help with buy-in. We also want to study the incidence rates for colorectal cancer screenings, of course, to prove the value of this work. And finally, we want to continue work until we hit 80%. It's a lofty goal to get that much of our population screened, but we think with these methods and the wonderful work of our teams, I think that's an achievable goal in every community that we serve. And I believe that's the last slide. Could you advance the next one, John? Yeah, thank you. That's the end of our presentation. Really appreciate everyone's attention today.
Wow. That was great, guys. Really, really thorough and well thought out and concise. Gary, should I just jump in with a few questions? And I know there've been questions going on. You're still on mute, Gary. I think you guys have been answering a lot of those questions. Let me take the prerogative. First of all, congratulations. I loved your whole systems approach and the driver diagrams and the way you thought about the whole thing was fabulous. It was a great demonstration of quality improvement work with dramatic impacts. This is more of a statement, but I guess I'll let you reflect on it, that, I think it's interesting, and we've discovered this throughout the entire health system. By encouraging annual wellness visits, we get so much with that, right? I mean, when we, whether it's hypertension or colon cancer screening. So that's one statement, and I'll let you guys reflect on it. The other one is, while doing this, you said, hey, wait a minute, what's with the patient portal? We're not, how do we enhance the use of the patient portal and engage patients in different ways and use it as one of many ways of connecting to people? So first of all, thoughts around annual wellness visit. How did that come about? How to do it better? I know that's a system-wide goal, and it seems to work.
Yeah, I can start. I think both of those are great comments, Dr. McGinn. When it comes to Medicare wellness visits, you're so right. It lifts up every metric. And also, there's just a special kind of check-in that we have with patients during this time,
Yeah.
When these visits are done well, the medical assistant asks a lot of the screening questionnaires before the providers walk in the room. And so when we walk in, we're able to really have intentional conversations and really just connect in a different way. And a lot of that is just around the standard work we have about how the wellness visits are roomed from the medical assistants. And then when we get in, as you said, to your point, we're able to screen for blood pressure and have conversation around it. We're able to screen for cognitive impairment and have a discussion about it. And so I think the more that we do it, there's just so much fruit that comes out of it. And just in response to your second point about promoting the portal, we do that in a variety of ways. And I think one thing that COVID taught us is that there is a lot of virtual care that we can do in a really, really valuable way for both providers and patients. And with a lot of the optimizations that we have around the portal, it allows us a lot easier ability to interface with patients virtually. So I think it's another way that we can promote it to patients. Michael, I don't know if you have anything to add.
I'll let Mike jump in a minute, but the one thing I know as a general internist my practice was, I always said I was a specialist in older adults with multiple chronic illnesses. Everybody seemed to be on Coumadin in my practice, but when you make the wellness visit really about not managing the chronic illness, but stopping and pausing and literally thinking, okay, what am I doing on the prevention side? But sometimes we have a hard time with that. And I think it's so important to do that. All right. And Mike, do you have any, by the way, Mike, you kept saying scoping out the problem. I don't know if you're trying to be punny in that by talking about colonoscopies, but I just thought I'd point that out. I don't know if that was intentional, but go ahead, Mike. Did you have a comment? And then Gary, you go.
What I would say is by far the Medicare annual wellness visit has really been our recovery strategy as a medical group throughout the pandemic, and as you said, all the benefits that come along with it. Barbara asked a really good question in the chat box earlier, and one thing, there was so much opportunity for us whenever we really first started this improvement journey. And when we started it really 3 years ago and implemented this quality metric, we were at 47% screened, and we're at about 71.6% screened today. So we didn't know where the variation was when it comes to an equity standpoint. But since we've improved drastically over these past years, and we've really used the annual wellness visit as a target for screening, we're beginning to see where the variation and disparities are. And really, it's those patients in that 50 to 55 range, and it will be even greater when we move to 45 to 50 in the future. And one thing that's working against us locally as well in the younger populations is that our state Medicaid program does not pay for the FIT DNA test. And what I would tell you about the FIT DNA test, we always offer colonoscopy first, and through shared decision making, we then move to FIT DNA and FIT third, is that we have a 70% compliance rate with FIT DNA. And they really have a great patient navigation program that really engages their patients to finish that. And during the pandemic, they would drop off the FIT DNA at you. UPS delivers it to your porch, and they'll come pick it off your porch, and then we'll get you your results. But Medicaid does not pay for that, and that creates a greater disparity in that population. And we're starting to see that not only on the payer side, but we're starting to see where those disparities are across our different races that we serve.
And do they pay for colonoscopy? I'm sorry, for Cologuard?
They do pay for colonoscopy and FIT. They do not pay for Cologuard.
Okay, they pay for colonoscopy and FIT. Okay.
And what the evidence does show with FIT testing is that you get about a 44% compliance rate in year one, but in year two, thinking about it from a metric standpoint, it drops precipitously to about 12% and then into single digits in year three. I mean, you can make the argument that we're screening more patients and getting patients screened is ultimately the goal, but from a compliance standpoint, we do not see the gains maintained year over year.
Well, it sounds as though the platform for getting people in the screening chute, so to speak, is annual wellness visits, and certainly we've taken that approach across CommonSpirit in general. But it does that, and then you mentioned obviously the new recommendations about people 45 to 49. It's moderate improvement. It's a moderate benefit, type B evidence, and so forth. But also those people who are between 50 and 65. So what about those people? And are they included? And certainly there's the whole issue of Lynch syndrome and these younger patients who are developing colon cancer, familial colon cancer in their 30s. And has any of that been part of this work, or do you see that getting incorporated? And I guess by annual wellness visits, in a way, we leave out anybody less than 65.
I'll take the first half of this, Dr. Jansson. I would say yes, it is. Now, while we do prioritize annual wellness visit for our outreach strategies, when we implement new workflows and processes for our rooming, we implement them the same for all of our patients. So the goal is that every patient has the same experience. So the huddling, the forecasting, the pre-approved orders, those are all part of that rooming process to ensure those conversations are held to address their health maintenance gaps.
So you would offer that to a 50-year-old or a 55-year-old at maybe not an annual wellness visit, but hey, like this applies to you on the wall here.
Right,
Absolutely.
right.
Absolutely. And I think to your question about what about the 45 to 49-year-olds, I think we still have some work to do to make that bolder in our care gaps within our electronic medical record system. That's some work to come. And a lot of that, I think, will be driven by the voting that will happen from NCQA and HEDIS. But I can tell you that we've already socialized in our provider meetings that this is something we should be talking about with patients, to have shared decision making for that unique group of patients. We're all aware that colorectal cancer is showing up in younger and younger populations. So I wanted to also just speak to Shauna's question. She asked a really good question about shared decision making and the impact that's had on patient compliance. A big part of it is, and what we socialize with our providers is, if people don't want to do a colonoscopy, we kind of just need to be okay with that, but to continue to encourage and then when you move to Cologuard, Cologuard is so convenient. And a lot of people have benefited from education around that, because it used to be you had to fill out the 3 cards, and that's still available. But when we promote Cologuard and the convenience of it, it's had an enormous impact on compliance for people that don't want to do colonoscopy.
Well, you guys have highlighted, so many key steps in quality improvement, and you've certainly mentioned shared decision-making several times, and doing it right, training people to do that. Are you, I think is, we assume doctors know how to do that, but I think what you just highlighted is you have to be comfortable with, hey, we all want everybody to get a colonoscopy, it seems, but hey, these are alternatives, and make sure to engage patients in that. So really, great work on your part to take part in all these different aspects. So it's really great demonstration. Gary, any other questions before we?
Go ahead. I just wanted, so, quite honestly, when I came to visit the Pacific Northwest for the first time and met Michael and the team, and I thought, wow, this is the most technologically capable group I've seen. And I still think that's the case in terms of your ability to leverage Epic and do all these great things with it. But what would you say for what kind of a team would you build? So let's say you picked another medical group, almost anywhere in the system, who has the average use of their electronic health record, but not at sort of that advanced optimized level that you do. Who do you need on that team? Like a physician champion, a quality champion, who else?
That's a really great question, and I would say that's where we started here in the Pacific Northwest, is with a blank slate. So that was a great opportunity for us to build out this entire program. The team we built in our population program, we really focused on 4 key strategies. And first and foremost, that's providing custom analytics, providing education, robust chart abstraction and gap closure, and then facilitating QI projects, all in support of our value-based programs, the ACO, and the Washington State Community Checkup. So we have a very focused scope. Now, it's a very large program, so we have north of 30 value-based programs right now, a large ACO and a large medical group. But I would say we had, it's a modest-sized team. We have a group of 2 data analysts, 2 abstractors, 5 nurse educators, and then there's a dyad with the medical director and director that really drive performance. The primary focus to date has been on primary care. We believe that's the backbone of the healthcare system and where you can drive population health. But we are beginning to expand into our specialty practices and are now present with population health programs with endocrinology, women's health, and also pediatrics. So even though we have a limited program, we've been able to scale it past primary care at this point.
Good stuff. Really, really impressive. Thank you both very much for doing this work. And as you know, Gary and I are very passionate about stealing best practices and elevating the game of the health system and creating clinical standards and introducing evidence-based care in a standardized way. So we'll be leaning on you guys for your expertise, your experience, and to share it with other folks. So thank you from the health system. And Gary, I'll let you say your last words and we'll say goodbye.
Thank you very much. And we're entering into this new era of clinical standards, and it takes many shapes and forms, like how do you manage X, Y, or Z. But I think this process, we have an opportunity. I know Shauna Sharp's on the line, and she's working with 3 of our markets right now developing these programs. And so we would really appreciate the opportunity to collaborate with you as we spread this across the system.
Good pleasure.
Just to say, I know this isn't your first rodeo in presenting, that you presented to the American Cancer Society and lots of other folks, NBC today, I don't know, but I think you've made the rounds with this, if I'm not mistaken. Is that right?
Yes, sir. We had the opportunity to present at the National Colorectal Cancer Roundtable in November as well. So really just trying to share this journey so we can help everyone.
That's how we heard about it. Thank you so much.
All right. Take care.